All right, let's go ahead and start for this evening. Anyway, this is the kind of the beginning of the important part of the airway. And anyway, in this first slide here, it talks about the primary component of caring for a patient is ensuring they can breathe adequately. Please keep in mind that if you can't breathe, nothing else much matters. So in about 4 to 6 minutes, you're in a lot of trouble. So, you know, I'm not breathing minutes after that, you're probably going to end up being dead. So, anyway, if any part of it is disrupted or whatever, we're going to talk about the pathophysiology and kind of what goes on, you know, stuff with carbon dioxide and offload of oxygen. So, we're going to kind of talk about that. And this is, again, this is a very, very important. So, all right, we saw this slide last week that kind of shows you the upper and the lower airway, and we're going to kind of talk about each part as we go. Anyway, you'll notice the pulmonary capillaries here cover the alveoli, and again, I'll mention this. I'll probably mention this 2 or 3 different times. The alveoli are 1 cell thick, and the reason that they're 1 cell thick is that way the oxygen can be picked up quickly and the carbon dioxide can be offloaded very quickly. So around these alveoli are the pulmonary capillaries. So that way, with it being 1 cell thick, then the oxygen can go directly into the arterial system, you know, to be circulated, and then the carbon dioxide can be picked up and breathed off. So with it being 1 cell thick, you know, and then very, very heavily covered with capillaries or whatever, it makes that occur very quickly. Now, we're going to be talking about some things that would inhibit this with capillaries and with stuff that would be in the alveoli or injuries or whatever. We'll talk about that as we go. All right, so again, it helps us breathe and ventilate or whatever. So you have the upper and lower airway. So the upper airway starts with the nose, the mouth, the oral cavity, the pharynx, larynx, as it says here. We'll kind of talk about. I'll show you these, and we'll kind of talk about each one of them, kind of what they do. And this is important. You can have, you could put someone in a room where the temperature was at 0 Fahrenheit, and you could, you know, put dirt or something circulating in the room. You know, as long as you're able to breathe through your nose, it warms, filters, and humidifies it, the air. And in fact, just to give you an example, the nose is so efficient. Now, if you're breathing through your mouth, you lose a lot of this ability. But if you're breathing through your nose, inside of your nose, there are little, what they call turbinates. And it's little shelves and little pockets and things like that. So you create turbulence in the air to the point where it's filtered. Now, I'll go ahead and mention this again. I mentioned this last week when we were kind of talking a little bit about the airway with anatomy and physiology. The entire airway system is covered with epithelial tissue. So that's mucus producing tissue. And the blood is very close to the surface. So that's part of the reason that it allows the filter or whatever, you know, in the humidifying. It's covered with little hair-like follicles called cilia, and these produce mucus. So the thing with this cilia catches the any kind of junk that comes in through your nose or whatever that you have. And anyway, then it kind of the mucus kind of catches it or whatever, and then you kind of try to kind of blow it out. Then you have the pharynx itself, extending from the nose and the mouth down to the top of the trachea. I'll kind of show you some pictures of this in just a second. All right, this is it's not really a good picture, but it kind of shows the anterior portion of it. So up just to the left of the nasal pharynx, where you see those little like peas or bulbs or whatever, you know, those are the turbinates. So again, they create turbulence when you breathe in. Anyway, the oropharynx is the very posterior part of the throat. You'll see the anyway. I know all of you gone to the doc or whatever, you told them you had a sore throat, and the doc told you to stick your tongue out and say, ah, that's actually what you're looking at, or what the doctor's looking at, the oropharynx, to see if there's a lot of drainage from down the back, see if it was red, or sometimes you'll have pockets of pus on it, got a real bad infection. So anyway, this is kind of the anterior portion of it. All right. We talked a little bit about the epiglottis. The epiglottis is, as it says here, superior to the larynx or whatever. But when you swallow, the epiglottis is a little tissue, skin piece of tissue or whatever that actually closes down over the trachea when you swallow. So whenever you swallow, that way no water or Coke or coffee or whatever you're drinking, actually gets down into the trachea itself. Or any food that when you swallow, any food that you're eating or whatever, actually is pushed down into the esophagus or whatever, and that way it doesn't go down into the trachea. Any water, food, Coke, anything like that that gets down into the trachea or whatever can actually make it down to the lungs, and it causes a horrendous infection. So you see this with a lot of real old people. So again, we had talked about the sticking your tongue out and saying, ah, this is kind of what you're seeing. And then the interesting part of this, I'll go ahead and mention this, kind of where the uvula is, the nasopharynx, oropharynx, in that area. There is a bundle of nerves that come down through that area from the brain. And this bundle of nerves is your gag reflex. And there's several other things that are kind of in that area. It actually can cause you to slow your heart rate down if you start gagging, like you're trying to vomit. Another thing that it does is if you have stimulation in this area, whatever, the first thing that it does is it causes bronchoconstriction. So your bronchioles, and we'll talk about those in a minute, you've got your trachea and then the bronchus and then the bronchioles, whatever. It causes bronchial constriction. So anything that triggers or that irritates this bundle of nerves can cause bronchoconstriction. And anytime you constrict, that cuts down the oxygen exchange, or the exchange of air, basically is what it does, or the ventilation side of it. So you kind of have to be careful with that. So if you've got someone who's still with it, and you put in an oropharyngeal airway, now I'll talk a little bit about oropharyngeal airways, but we actually will go over it next week, and you'll see and get to use an oropharyngeal airway and how it works or whatever. But these things are actually long enough that they actually can come down behind the tongue. So if you put it in and they start vomiting, acting like they're retching or wanting to vomit or whatever, then the patient is still with it. They're still alert too much, for you to put it in. So you need to get it out, because you definitely don't want them vomiting. So we've talked about the larynx, and we've already talked about the Adam's apple or whatever. So if you have any issue about where the Adam's apple is, take your hand and put it on the front of your neck, and then just swallow, and you'll feel it move up and down. The Adam's apple kind of feel moving up and down. So that, again, this is kind of a thyroid or a cartilage or whatever, with kind of a bony type membrane. So anyway, you'll notice the trachea is covered also with cartilage, and the reason for that is to keep the trachea open. So anyway, the cricoid cartilage is the first ring of the trachea, and you'll see this forever and ever. So that might be something you would see on a test. So I would remember the cricoid cartilage is the first ring of the trachea. And then the glottis, as it says here, is the area around the vocal cords. All right, we've already mentioned the trachea and how important it is. It's the conduit for oxygen or air, to actually make it in. And you have the bronchi, and then the actual lungs. And remember, the lung tissue itself is very fragile. So it's much like a sponge. So it's very spongy. You'd be surprised how spongy it is. It's kind of weird to feel it. Anyway, the trachea, as it divides at the carina, and again, this is something that you would see on the test or whatever. It's going to ask you where the carina is and what it does. So it's where the two lungs of the bronchi splits off into the two lungs, the left and the right. The left side is more of an acute angle off to the left. Josh and I, being paramedics, we've done endotracheal intubations, and it's very common with everyone to push the endotracheal tube down a little too far. And what happens is it goes in below the trachea or below the carina, whatever, and it'll always go down into the right lung if you push it too much. So you're always, once you've got it in or whatever, you're always listening for breath sounds to make sure that they're equal in both lungs. So again, the bronchi are supported by cartilage or whatever. In fact, this cartilage goes all the way down almost to the alveoli, and the cartilage kind of helps keep the bronchi open. So the bronchi does exchange a little bit of oxygen, but most of the oxygen exchange is made at the alveolar level. So please keep that in mind. All right, so here's a good example of whatever now. I know it talks about the main bronchi or whatever, but again, I'll just throw this out here. Remember, when it starts splitting, it actually divides 22 times until it reaches the alveoli. And I don't think you see that on a test, but it's good information to know. So anyway, the bronchioles are made of smooth muscle, and they're able to, with it being smooth muscle, they're able to contract and expand. And that's one of the things that kind of helps. And I'll kind of talk about the medication here that kind of affect them in just a little while. So anyways, it says your oxygen is transported back to the heart and distributed to the rest of the body. So we'll kind of talk a little bit about this. All right. You'll see the thoracic cavity here. So a lot of very important anatomy is in this area. Now the area also behind, I'll go ahead and mention this, behind this sternum, whatever is also, this whole area is known as the mediastinum, and it'll come up on us as a slide here in just a little while. But just remember, there's a lot of important anatomy in here. Look at your vena cava, look at your aorta, your large arteries and veins are there. You've got the lung tissue itself, you've got the heart. The diaphragm is important. You know, it's the main muscle for breathing, and we'll kind of talk a little bit about that. So anyway, as far as the process of breathing, you know, the intercostals kind of move upward and lift up, and the diaphragm moves down, contracts downward or whatever, and it creates negative pressure. So that's where the air actually comes in. So the diaphragm is responsible for probably 80 or 85% of the breathing. So you got to have that muscle. It's a very, very, very thick, very important muscle. Anyway, if you hiccup, anyone who has hiccups or has ever had an issue with, it's a spasm of the diaphragm. That's what hiccups are. So mediastinum, I mentioned a minute ago, heart, great vessels. I mean, many of your very, very, very important anatomy is in this area right here. So you'll hear mediastinum mentioned periodically, so you'll know where that is. All right, very important slide. So you have to be able to breathe, and you have to be able to pick up oxygen. You have to be able to offload carbon dioxide. But you also have to have a heart, you know, in order to be able to circulate it. But the other part of it that's not really mentioned here is you got to have blood. So the blood carries it. We'll talk about the hemoglobin in just a minute. But you actually have to have enough blood, and your blood has to have the ability to be able to carry the oxygen and remove the carbon dioxide away. So we'll kind of talk a little bit about that in just a second. But the respiratory and cardiovascular, absolutely, you got to have those, but you also have to have blood. So they all have to work together. So again, I don't like reading the slides, but these are very important. So I'm going to kind of just reiterate very quickly. So ventilation is the act of moving air in and out of the lungs. So the oxygenation is loading oxygen molecules onto the hemoglobin. Hemoglobin is in the blood, on the blood. Then respiration is actual oxygen and carbon dioxide of it, alveoli, making its tissues alive. So again, you have to have hard to push the blood, but you have to have the filter of blood to be able to carry it. So again, it doesn't mention very much about blood, but you got to have an adequate amount of blood. All right. To breathe in takes energy. So it's the active muscular work of breathing is breathing in. So as long as everything's working normally, whatever, it takes you 1 second to take a breath inward, close to a second to take a breath inward. So again, the diaphragm moves downward, the intercostal muscles contract, and lifts, so it can create negative pressure. Basically, that's how it works. Again, this is just a little bit of review. So, and I mentioned this the other day, the IE ratio. I is inflation. So that takes energy and muscular work. So IE ratio, expiration means relaxation or whatever, but it takes 2 seconds to get the air out. Okay. So 1 second to breathe it in, 2 seconds to breathe it out. Okay. So you're just relaxing, basically, is what you're doing. Everything's going back to normal. All right, this is a good example here, of kind of breathing out, basically. All right, we mentioned this the other day. Tidal volume is usually about 500. Then you have dead space of 150. All right, this dead space is actually the air that's in the trachea that doesn't get exchanged, the air that's in the bronchi, the air that's in the bronchioles, also the air that's in the larynx and the oropharynx and the nose, and, the back of the mouth. That's where it's at. So there's 150 of that. You literally are not exchanging, even though we talk about the tidal volume, you pull in 500 or whatever, there's only 350 of it that actually makes it to the alveoli. So there's a lot of things that can affect the tidal volume. If you've got someone who's breathing very shallow and very, very fast, thing that may not be breathing in 500. So it may be 300. They're actually breathing in. But the dead space is constant. That 150 is constant no matter how fast or slow you're breathing. So if you're breathing in 300, if you're breathing very fast or whatever, and you're only breathing in 300, then technically, once you deduct 150, they're only exchanging 150. And that's not enough. Or let's say you're breathing too slow. Now again, you'll see this over and over. The normal respiratory rate, you'll see this on the test. It's 12 to 20. So let's say they're breathing 6 times. That may not be enough, depending on the person or the talking about. So there's, they can either breathe way too slow or way too fast. And we'll kind of talk a little bit about it. So exhalation, as I said, it takes 2 seconds to get the air out. It's a very passive process. So everything basically is just relaxing and going back to normal, and it just compresses and lets the air out, basically, is what it's doing. All right. As far as regulation of ventilation, I talked about chemoreceptors the other day. The chemoreceptors are actually in the carotid arteries, and they're actually in the aorta. So what they do is they constantly measure the amount of carbon dioxide. So as long as they're working normally or whatever, they will measure the amount of carbon dioxide. So if you're breathing very slowly or whatever, well, again, if I get out and start running around the building or walking around the building, whatever, then obviously my metabolism. So once you start speeding everything up, you have to start breathing faster, so you're need, not necessarily for more oxygen or whatever, but you're exchanging it very quickly, but you're producing a lot of carbon dioxide, so you're going to breathe faster than you breathe it off. So as long as everything's working normally or whatever, then that's actually what's happening. So this feedback loop basically just keeps, as long as your body is getting enough oxygen or whatever, then it'll kind of slow down. Basically. So anyway, it also measures the amount of pH that's in the blood. And what pH is the amount of acid in the blood or whatever, and also the sugar. So now I mentioned the hypoxic drive a little bit, and then Josh also mentioned the hypoxic drive a little bit yesterday. It's seen in people with end-stage COPD, especially emphysema, people who smoke for 30 years. That's where you see the hypoxic drive. So what happens is these people get used to the chemoreceptors get used to because your lungs are not working as well. Your carbon dioxide level is higher. So instead of it being a normal 40, it may be 55 or 60. But what happens is it kind of tricks your chemoreceptors. And so they actually get used to a high amount of carbon dioxide. So what happens is your body switches over and starts measuring the amount of oxygen that you're taking in rather than the amount of carbon dioxide. So that's referred to as hypoxic drive. It's measuring the amount of oxygen rather than carbon dioxide. All right, again, the hemoglobin is on the red blood cells. You have to have hemoglobin in order to carry. It's what the oxygen is actually loaded onto. Carbon dioxide. It offloads the oxygen and picks up the carbon, so it's actually what carries the oxygen and the carbon dioxide. So again, you have to have enough blood. You can't be, can't have someone who's bled to death or whatever, and there's just not enough oxygen, not enough blood to carry the oxygen. So we've already talked about the oxygen and carbon dioxide in the alveoli, whatever, So again, you have to have energy in order for this to occur. All right. So pulmonary respiration or external respiration brings fresh air in, and then it exchanges or whatever, and then you're just like on this slide, it's showing the oxygen is going in, the carbon dioxide is actually going out. And I'll mention this again. You see the alveoli and the capillaries. Again, they're very tightly attached to the alveoli, and the alveoli is one cell thick. So we'll talk a little bit more about the alveoli in just a minute, or some things that would. So again, here's a good example. So you'll see how thin it is, and it's actually going into the tissue cells. So it's actually how it offloads. So as long as everything is working normally or whatever, and again, you have to be breathing normally or able to ventilate. You have to be able to have enough oxygen. You have to have a heart to be able to circulate the blood. Then you have to have blood to be able to carry it. So, and then be able to offload it. All right. I mentioned chemoreceptors, so they do monitor the oxygen or whatever, but they monitor the carbon dioxide more. Now, a lot of people they see hydrogen ions and they panic and say, "Oh God, what is hydrogen ions?" Hydrogen ions is acid. That's all it is. So it's measuring the amount of acid actually that's in the blood. So your blood actually has what they call the buffer system, and it's you actually have bicarbonate that naturally occurs in your blood, and it actually absorbs the acid. So that's what they call the buffer system, and it responds second system is your breathing. So you start breathing it off, becoming tachypnic. And that's the medical term for fast breathing. But just don't panic about hydrogen ions. All that means is acid. So then again, we've already talked about the pH of the cerebral spinal fluid. So anyway, this feedback, as long as everything gets back to normal, or whatever your need for oxygen or what's required by the body will actually slow down. All right, you'll see this word over and over again: ventilation perfusion mismatch. So as you see this, air and blood must flow directed to the same place at the same time, or whatever. So as long as there's enough ventilation, as long as there's enough blood, as long as the heart's working normally, as long as they're working, as long as each one of them are working normally, whatever, then they'll be matched and there's no issue with it. So anyways, it says here failure to match, causes all kinds of abnormalities. We'll kind of talk a little bit about what some of those are here in just a second. So let's say your gas exchange does not take place in the alveolar level. And I'll give you some things that would affect the gas exchange. Let's say you've inhaled, I work for the burn center. So let's say someone is in a house fire, whatever, and they inhale superheated gas. Then immediately it's going to go to the alveoli and it will cause swelling or whatever. So it causes the alveoli to leak or whatever, or the epithelial tissue to leak and they start swelling or whatever. That would stop the gas exchange. Although we've been talking a lot about COVID, the issue with COVID is these people produce or they develop COVID pneumonia. So this pneumonia produces a lot of mucus. We've already talked about the epithelial tissue and it being having a lot of mucus or whatever. What happens is this mucus occupies the alveoli and there's no gas exchange that so this lack of oxygen in the bloodstream or whatever, you're suffocating for some reason or whatever, or you're in a low oxygen environment, whatever that would be, not enough oxygen. So what's happened is it can't offload the carbon dioxide, so the carbon dioxide is recirculated in the bloodstream, and it becomes you can't get rid of it, or whatever, the carbon dioxide level just rises like crazy. So that's part of the oxygen or ventilation perfusion mismatch. So I'd mentioned infections, allergic reactions. Let's say someone's allergic to a bee sting or whatever. The first thing they do is they'll start wheezing. Wheezing means bronchial constriction. They start making noise. A tongue obstruction or whatever. Someone's taking an overdose of heroin or whatever, and they're breathing 4 times a minute. Extrinsic, like it says here, trauma. Someone is bled to death. There's not enough blood. One of the lungs is collapsed. Or there's blood inside the lung. That's part of trauma. And again, we'll kind of talk about this as we go. Some external factors, whatever, atmospheric pressure. Let's say you decide you want to go skiing in Colorado and you're at 15,000 feet. Okay, the oxygen pressure is very, very low out there. I mean, and instead of it being 21%, it may be 15%. So your body is used to being at 15 or 21%. So it has a lot of problems because it's just not used to it. So I mentioned pneumonia a minute ago. Pulmonary edema is what you would see from, mucus, junk in the alveolar area. And then COPD or emphysema, whatever it is, again, from damaged lungs from smoking is actually what it is. All right. A simple pneumothorax is just a lung that's collapsed. A tension is, see that from a gunshot wound where there's a hole through the chest or whatever. So it causes the lung to totally collapse. But then what happens with a tension is it actually lets air out. You can have blunt force trauma to the chest or whatever, where you break a rib and the rib goes in and punctures the lung itself, and it starts letting air out. What happens is the more you breathe, the more air that escapes into the chest, and it starts shifting starts compressing, starts moving over and it compresses the good lung. So it's actually an emergency. The only thing you can do for it is to put a needle in their chest. And unfortunately, that's not something you basic can do, paramedic can do. That's about it. Open pneumothorax, you can see that from a gunshot wound. Hemothorax is, again, trauma, and there's blood. They're bleeding inside of the chest cavity. On one side, you can actually lose the majority of your blood volume just in your chest. And then hemopneumothorax is blood plus also a damaged lung if the lung has collapsed. So usually that's what you have if you have any kind of there's some blood involved. So other things, again, blood loss, anemia is lack of iron. So you have to have iron in order to have hemoglobin. Hemoglobin is the oxygen carrying part of the blood. So hypovolemic shock is loss of volume, either from, and I mentioned a minute ago, they bled out or lost blood, but you can also have it from hypovolemic shock from vomiting, just constant vomiting, or really, really, really bad diarrhea. So anytime you're losing water, anyway, then you can become hypovolemic. Vasodilatory, you see that from, have that from a brain injury, overdose of drugs, severe infection causes vasodilatory shock. A lot of the COVID patients, before they die, they vasodilate out, and they can't really do much for them, So we'll talk about, now I know this talks about aerosol generating procedure or whatever, CPR. Anyway, nebulizing treatments, we'll talk a little bit about those. Endotracheal intubation, that's paramedic skill. In continuous positive airway pressure is CPAP. So if you have anyone who has sleep apnea or whatever, and I know probably all of you know someone who has sleep apnea, and they wear a machine at night and help them breathe, that's CPAP. So we're going to kind of talk about this. We'll talk about it a little bit, but next week we're going to do an airway lab, and you'll get to see all of this stuff and get to work with all the different equipment. So adequate breathing, 12 to 20. And again, I've talked, a couple of exceptions. You had someone who was breathing 24 times a minute, that breathing normal for them. You had someone who was in their 20s and 30s, and they were a marathon runner or whatever, their breathing rate may be 18, or they have very good, very well developed, and that may be normal. So 12 to 20 is just a general baseline of where that you got to kind of do an assessment of the patient and figure out exactly what it is. So inhalation and exhalation, whatever you're looking for, a regular pattern of whatever. Now here's the other thing too I'll mention to you. Whenever you first walk in the room, you look at someone's breathing, observe their work of breathing. Are they focused on a particular, do they not really want to talk to you or whatever? They act like they're kind of out of it, or are they focused on a picture on the wall or something like that, and they're just really focusing on their breathing. If they're making any kind of noise or whatever, with breathing, whatever, that's an issue. Okay. Let's say you start talking to them and ask them questions or whatever, and they'll say 2 or 3 words to you, and then they have to stop and get the breath. That's another sign of trouble breathing. So you want to listen for the breath sounds, listen to any noises, again, that they might be making or whatever. Chest rise and fall, and then the adequate depth of tidal volume, which is normally about 500. That's just average, about 500 with most people. All right, again, anything less than 12 is an issue unless you have someone in really good shape. More than 20, it's not a problem if you get up 23, 24, maybe even up to 25 or whatever. That's not an issue or whatever, unless it's continuous. Now, once you start getting up around 30 or whatever, then the tidal volume starts dropping because you're breathing so fast. So any kind of irregular breathing, you know, with their any kind of diminished, absent, noisy breath sounds, where we'll talk a little bit about breath sounds a little bit later. So again, look at the work of breathing, you know, any kind of reduced flow in and out through the nose. So you can observe them more and just look for normal breathing. You know? So you can observe that when you first walk in the room. Any kind of unequal or inadequate chest expansion, and we'll talk more about that when we get into trauma. Again, any kind of increased effort. Sometimes you'll see children who will grunt. That's an effort to try to have a better gas exchange. Shallow breath, shallow depths, you know, very, very shallow breathing. And here's the other thing that you want to look for. Pale, you know, I mean, some people have pale skin, so that's not as big a deal as cyanotic is, and what cyanosis is lack of oxygen. So you'll see it around the lips and in the nail beds of the fingers. So you'll get real blood, and it's very obvious. So anyway, the skin pulling in and around the ribs or around the clavicle, wherever you're getting inspiration. You mainly see that's called retraction, and I mentioned that the other day. You typically see that in children, whatever you can see it in adults, but they have to be very skinny in order to be able to see. You can't, anyone with a thick chest wall like myself or Josh or whatever, you wouldn't see retraction in us. All right. As it says here, anyone who appears to be breathing at the heart is stopped. That's called agonal gasp. So you want to get started. If that has no pulse, you want to start CPR. That means agonal gasping. So you want to start CPR. Shane Stokes, it says here, sometimes seen with stroke or head injury or whatever, and it means it's been going on for a while. So they have some sort of brain injury. You see Shane Stokes. A lot of cancer patients, right before they die, they'll have Shane Stokes type of respiration or whatever. So when you start seeing those, and what they do is they breathe very deeply for like 30 seconds or whatever, and very, very deeply and very fast or whatever, you know, very hard for about 30 seconds, and they slow down and they almost stop breathing or whatever. And it's very, very kind of weak breathing or whatever, you know, and that'll go on for a minute or whatever. And then they pick back up and breathe very hard, very fast, again, very deep, you know. That's not good. So most of the people who have Shane Stokes or whatever, they're not going to be here that long. And I hate to put it that way, but they're not long for the world. Right, you see ataxic with serious head injuries. Now, it all depends on where the injury to the head is, how they'll actually breathe. So I know they mentioned Shane Stokes or whatever, but you can also see ataxic. It's a very irregular pattern, as it says here. Kussmaul respirations, the place that you see Kussmaul most of the time is with diabetics. And I know this talks about metabolic acidosis or whatever. Let's say you've got a diabetic whose blood sugar is 5 or 600. That means there's a lot of sugar, but there's no insulin for them to be able to metabolize the sugar. So their sugar level just keeps rising or whatever. Well, sugar actually turns into a poison. So what's happening is your body is trying to breathe it off. So it's very deep, very rapid breathing or whatever is known as Kussmaul. And again, the most common one is a diabetic whose blood sugar is very high. And it's been going on for a little while. So it's the body actually trying to compensate what it is. All right, so anyone that looks like they're having trouble breathing, one of the first things you want to do is you want to put a pulse oximeter. And we'll I'll show you this, or we'll go over it next week. And anyway, the pulse oximeter actually tells you how much oxygen is in the blood. Now, your book will tell you that if they're 94 or above, then they don't need oxygen. If they're less than, if they get down less than that, then you need to at least put them on start out with a nasal cannula. If it's it's much lower than that, then you want to start out with non-rebreather, and we'll kind of talk a little bit about that. But if they're having a lot of trouble breathing or whatever, the first thing you want to do is put them on oxygen. And again, we'll kind of go over that. So pulse oximetry is part of any of your patient assessment or whatever. So all of you probably have seen hyperventilation. Someone gets scared or they're upset or whatever, you know, they're breathing very, very, very fast. What happens is they're breathing off their carbon dioxide. So if it keeps getting really, really bad or whatever, it'll cause their skin to, or their hands to kind of cramp, and they'll draw. They used to let them breathe in a paper bag, but they don't do that anymore. So what they were trying to let them do is rebreathe some of their carbon dioxide. So that means they're breathing way too fast. High carbon dioxide level, it means they're not breathing very well. And again, apnea is they're just absolutely not breathing very much at all. So capnography, we'll kind of go over this too. Measures, the normal range is 40, but 35 to 45 is actually what it is. But there is a nasal cannula that you actually can measure this with. It actually, you can actually administer oxygen or whatever, but you can, the cannula actually fits to a monitor, and it'll give you that number, 35 up to 45. Yeah, it could be higher than that if they were not breathing very much. So what you want to do is make sure that you have an open airway. So if these patients are unconscious or whatever, their tongue may fall back. And actually, the most common cause of an airway is your tongue. They get so relaxed or whatever, you know, that any of you that snore, that's actually what's happening. Is your tongue, you're getting so relaxed, your tongue's kind of falling back, and it makes you snore. So anyway, what you want to do is you want to get the patient in position or whatever, and open the airway, whatever. The best way to do is head tilt, chin lift, and we'll kind of go over that here in just a second. But you want to get them over on their back or whatever, where you can actually work on them. So as it says here, most common airway obstruction is your own tongue. So anyway, you want to move them as a unit or whatever. And then here's a pretty good example of the head tilt, chin lift. One hand on the forehead, and then your fingers on the chin, and you want to lift the head backward. That's what you want to do. So kind of be careful. Now, if they've been involved in trauma and there's an actual neck injury or whatever, then you don't want to do this because you can aggravate the neck injury. So we will work on this next week. All right, jaw thrust is if you suspect a cervical spine injury or whatever. Now this is a little harder. But what you're doing is you're actually holding C-spine control or whatever. But what you're going to do is you're going to use your thumbs to kind of push the jaw forward. And by pushing the jaw forward, it actually picks the tongue up off the oropharynx. All right, this talks about the airway. If the airway is open and the mouth may be closed or whatever, what they want you to do is the cross finger technique, and we'll kind of show you this. The only thing that you have to be careful is you want to make sure the patient is totally unconscious before you start doing this. If you put anything in their mouth, including your fingers or whatever, they could actually bite you, and it's not fun getting bit. So I'll go ahead and tell you that. But there's some other things that you can look at, you know, that we'll tell you, and I'll kind of go over that with you a little bit later. But just be careful about putting your fingers in the patient's mouth. You can do it, but be careful with it. So here's the jaw thrust maneuver, and we'll go over this next week. All right, suctioning. Several things you need to pay attention. If they're vomiting, and it's very common for these patients to vomit, or they can be bleeding. If you don't suction the vomitus out or whatever, then they can aspirate it, and any kind of stomach contents that actually gets down into the lung itself causes aspiration pneumonia. And mortality rate's 85%. So it's very hard to treat. The other thing is, let's say they've had some sort of trauma on their face and they're bleeding. If they bleed, once the stomach gets about halfway full of blood, then immediately they'll start vomiting up their own blood, because their own blood, even though it's your own blood, it's still an irritant to the lining of the stomach. So you'll end up throwing it up. And whenever they throw it up, it goes everywhere and it causes a big mess. So you want to be suctioning as much as you can. The one on the left is okay. That's a handheld suction or whatever, and you mash it like this, and it kind of creates suction. The best one is the wall mount or the hand operated, or not the hand operated, but the portable unit. Those actually work much better. The only problem with the portable unit is you have to make sure that the battery's charged, because it runs the battery down pretty quickly. So you want a non-kinking tubing, a very big tubing or whatever, and the reason for that is anything that's in the stomach or whatever, if it hasn't been long since they've been eating chicken or whatever, there's going to be some pretty large chunks of chicken come up, and it will actually, large chunks of meat or vegetables or whatever won't actually go through the tubing. So the other thing that I'll go ahead and mention while we're talking about this is keep a towel close. Or you can always use a towel to help wipe things out of the way, and it helps dramatically. So we'll talk about the different pharyngeal suction tips, the other plastic catheters or whatever. The catheters are for deep suctioning, and that's not something that EMT do. So we'll kind of talk about that in a minute. So this thing about checking the unit or whatever, you should have done that when you check your ambulance, make sure that everything's working. You have all the pieces of equipment that you need. This is important. You'll see this on the test. I'll go ahead and tell you this. You'll see this forever on the test. Never suction the mouth and nose for more than 15 seconds in an adult patient for more than 10 seconds. The reason for that, when you suction, you're actually pulling out oxygen too. So the suctioning can increase the hypoxia. So you're actually suctioning. It actually is gathering the oxygen. You're suctioning it out too. So again, suction the mouth as you need to. Right. Then you want to, if you have to suction or whatever, you want to ventilate for a couple of minutes or whatever, and then you can make the suction. Sure that you're ventilating. Oropharyngeal airways is a white-looking curved airway that goes in the mouth and it kind of fits down behind the tongue, and it helps hold the tongue up off the back of the throat. It does, it says here, it does make it easier to suction, but now it can be very irritating or whatever. So if you put one of these in, if they have any kind of gag reflex or any kind of life left in there, they will spit it out or they'll start vomiting. So you have to be kind of careful. So they have to be very unresponsive without a gag reflex. So again, you're not going to put them in a conscious patient. Now, nasopharyngeal airway actually goes through the nose, and it's for an unresponsive or someone with an altered. They can have an intact gag reflex, whatever. It actually goes through the nose and actually comes down behind the tongue. They have to be fairly long, but they're better tolerated than the oropharyngeal airway. Here's the other part about the nasopharyngeal. We'll talk about this. The inside lumen of them is fairly small, and so it's not like that. It's going to displace a lot of tissue, or if there's not a big hole in it, let a lot of oxygen through. So it's been generally recognized in the field, and I'll go ahead and tell you this, that if you put one in, then you probably need to put two in, so you may have one in each nostril. That works much better. Right. If they've had any head trauma, if their nose is broken, if they're bleeding, facial trauma, there's no or blood coming through the nose, that major facial trauma, whatever, reason for that is there's a plate kind of in behind the sinuses called the cribriform plate, and sometimes it will break. And it's anything you put up in the nose or whatever could go up into the brain. And I promise you don't want that. So here's the recovery position. So there's the patient kind of over on their side, and this allows for, this as long as they don't have any trauma. So it allows them to any kind of vomits or anything like that kind of come out. Actually. So anyone who's hypoxic, having any kind of trouble, never withhold oxygen, make sure that you always do that. So we're going to talk about a little bit about the cylinders now. You don't see there are a few places that have liquid oxygen or whatever, and whenever they actually turn it on, whatever, the oxygen becomes gaseous. But liquid oxygen, a small amount will last for a long time. So you see those on helicopters, whatever, a lot of times, fixed wing aircraft stuff. Sometimes you do see them on ground. All right, there is a pin indexing system, and I would kind of remember this, and we'll show you, this is the oxygen regulator itself, and we'll show you the pins next week when we actually go through the hands-on part of it. So the pressure regulators are a larger regulator. That's what you see in the ambulance itself. So it's a range of anywhere from 40 to 70, so it's much more high pressure. This quick connect female, actually attaches where, and that's where you put your oxygen. Flow meters, it's the actual little thing that sticks up or whatever. You'll see a little ball in the middle of it. You actually turn it on, and it shows you, the amount of oxygen that you're getting. We'll kind of go over this too. All right, a couple of things about oxygen. A lot of people have said for years that oxygen explodes. It does not explode. Now, if you have a fire and there's oxygen around or whatever, it's going to cause the fire department more briskly because it has oxygen push, very rich oxygen supply. So it doesn't explode, but if there's any fire around or whatever, it's going to make the fire bigger. The other thing about oxygen toxicity is if the patient oxygen saturation pulse oximeter is 94 or above, the patient doesn't need oxygen, so don't give them oxygen. If their oxygen is way lower than that, so that way you prevent oxygen seizure, oxygen toxicity. So anyway, keep oxygen away from sources of fire or whatever. Again, I'd mentioned 94%, so if they're about 94%, they don't need oxygen. So a non-rebreather, let's talk a little bit about this. So here's a non-rebreather. We'll go over this again next week. So it's a mask with a little reservoir, and the oxygen fills the reservoir, and you actually are pulling oxygen in. And it's got some little flapper valves on the side of it. So it allows you to give a pretty high concentration of oxygen as long as the mask is fitting very well. So it's a good way to give a high concentration of oxygen. So it says here, make sure the reservoir bag is full, because if the patient's breathing very deeply, they may empty that bag every time. So you've got to kind of keep that into consideration. Most common thing we use is a cannula. So the only problem that you'll run into with it is you give anywhere between 1 and 6 liters. The higher you get in the liters, with it hooked directly to the tank, it starts drying the nasal mucosa out. So, and it can cause pain, especially if they've been wearing the cannula for a while. So kind of keep that in mind. So it's for patients with mild hypoxemia. So this thing about them breathing through the mouth, they don't benefit that much from it. Now, they still absorb it some through the nose or whatever, but they don't benefit. They'd be better off with a regular mask than they would be with a cannula for breathing through their mouth. So partial rebreather, you don't see those too much. At the very top of the bag itself, it's open, and that's so it actually mixes with kind of what you're breathing out. So that's why it's called a partial rebreather. You don't see those too much. Venturi mask, about the only place that you see these is in a long-term care facility where they're measuring the amount of oxygen that the patient gets very precisely. And each one of these little colored things kind of, it gives you a percentage of oxygen that it will administer, like 24% at 4 liters, you know. So, but it allows you to measure the oxygen very, very closely. That's what it does. So the trach mask, these are very common. You see these in a lot of nursing homes or whatever, or long-term care facilities or whatever. So you may not have a tracheostomy mask or the actual mask that fits on the trachea itself. Not a problem. Use a pediatric mask, and it fits directly over or whatever. Or if you don't have a pediatric, you can use an adult mask, and it will fit directly over the top of the tracheostomy. All right, so we'll talk a little bit more about. So anyone who's out of it, their level of consciousness is altered or whatever. If they're not breathing, they're breathing way too fast or way too slow, that gives you an inadequate minute volume. Or if they've been breathing hard for a while, then what they do is they get tired, you know, fatigued or whatever. And that's one of the issues that we see with COVID now, is these patients get tired and they end up on a ventilator. So this is a bag valve mask device. So, and I know this talks about explaining the procedures to the patient or whatever. Most of these patients, they're not going to let you put a bag valve mask over their face and start pushing air in them unless they're out of it. So we're going to kind of talk a little bit about how these things work. So there's the mouth to mask, and we won't use that too much or whatever, but the 1 to 2 person bag mask device is what we actually will end up using. You're actually better off with two people, but you can do it with one. It just takes a good bit of practice. So anyway, positive pressure ventilation is with a bag valve mask or with a ventilator or something like that. That's what it is. So you're increasing the intrathoracic pressure, you know, and that's one of the problems. If you're breathing, if you're overventilating them too much, and that's one of the things you can get into. And we'll kind of go over this. The other thing, air is forced into the stomach, and once you push too much air in, it'll come back out, and it brings anything that's in the stomach with it. So it just made the airway worse. So we don't do mouth to mouth. So mouth to mask is what you want to. So if you got some sort of little barrier device or a little key ring with a barrier device or whatever, then you at least need to get you one. They're very cheap. So anyway, here's the BVM, and this is one of the most important pieces of equipment that you have. Provide the good seal. Just have to. It takes a little time to get used to using it. That's the only thing. If you ventilate too much, what you should do is, once you're ventilating with a bag valve mask, you know, whatever, what you want to do is you want to give them a ventilation over about a second or two, and you want to just see the chest rise. You don't want to push any more than that, because if you do, then the air starts going in the stomach and going in the stomach, and that's not a good thing. So ventilate at the appropriate rate and at the appropriate volume. So that doesn't mean that you're going to mash, I mean, just totally, you know, mash the bag flat every time. We'll talk more about passive ventilation or whatever. Not a lot of people use it or whatever, but Anyway, there's an automatic transport ventilator, and this is, as it says, manually triggered device that's attached to a small. So all you, it's a lot like a ventilator, but it's mainly for CPR. So what you do is you set the tidal volume and you set the rate, and it basically it takes over as a BVM, and it will ventilate the patient for you. It's mainly for CPR or someone who is absolutely not breathing. That's what it's for. All right, so here's your CPAP mask. So anyone with obstructive sleep apnea or whatever, this is actually what they wear, and it works very, very well. You actually can hook these things up, or whatever. We'll kind of talk a little bit about. So this helps these people. It helps people breathe, increases pressure in the lungs, opens the alveoli. So if they've got a very low blood pressure, whatever, if they're out of it, you can't use it. We'll kind of talk a little bit about that. So they have to be alert and able to follow commands. Patients breathing rapidly or whatever, the pulse oximetry is reading less than 90 or whatever. Again, these things work very well. You don't want to use it if they're, as it says here, if they're in respiratory arrest, if their tidal volume is very low, they can't speak, they can't follow commands, they can't swallow, whatever, or again, the blood pressure is very, very low. You wouldn't want to use it. Some issues with it is if you get the pressure up too much, you can cause the lung to pop and cause a pneumothorax or whatever. If they have a tracheostomy, it doesn't work because whatever they breathe in there comes back out through the hole. So if they've got any kind of active gastrointestinal bleeding, or if they're vomiting or whatever, then the mask is not going to fit on their face. Any kind of facial trauma where they're bleeding, cardiogenic shock or whatever. Now there are people who cannot tolerate the mask. This is always probably the biggest thing that is if they're having trouble breathing, whatever, you put something on their face, they're not going to like it. So a lot of these people, you actually have to talk to them for a minute and say, just try it, and sometimes you can talk them into it. So anyway, there's numbers on it, what graduated numbers or whatever, so you go by your protocol, but you don't ever want to get more than 10 of these. So, and again, a lot of these patients are claustrophobic or whatever, so you want to kind of be careful or whatever. If they fight it to the point where they don't like it and they just can't get used to it or whatever, then you probably need to switch back to a non-rebreather or anyway, here's a stoma in the neck, and you'll see these sometimes with patients, whatever known as a tracheostomy. Right. If they have a tracheostomy and you need to ventilate the patient, they're not breathing, take a small mask, like from the BVM for the baby, and it actually will fit directly over the hole, and you can mash down and then ventilate with your bag valve mask. It works very well. Well, airway obstruction. Again, if it's totally obstructed, or wherever someone gets choked on a toy, or a child gets choked on a toy, or someone's eating a piece of chicken and they get choked or whatever it is. Right. So if they have a mild airway obstruction, they can still exchange air, if they're breathing, if they can cough. And try to get it at their coughing of the patient. Let the patient do as much as they can do to try to cough it up. The only time you intervene is if they get to the point where they're starting to go unconscious or whatever, they can cough it up. So here's the universal sign of choking. So they're grasping the throat and they're having loss of breathing. If they legitimately are choked, they cannot breathe or talk or cough. So again, they'll start turning cyanotic. So again, if they're unresponsive, they're not breathing, chest compression. Abdominal thrusts, and we'll kind of talk a little bit about those. We'll kind of do. I'm pretty sure we'll do a lab of those. Show you exactly how to do. This is important. Any kind of dental appliance or whatever, a crown or dentures or anything like that, if they will stay in, you're better off leaving them in. But if they keep moving around or whatever, then go ahead and take them out. Make sure you give them to a family member because people get upset when you start losing their dentures. So facial bleeding, we've already kind of talked a little bit about that. Face bleeds very profusely. So again, if they start, you start going down the into the airway, what you get, that's going to cause problems. All right, this is kind of an ALS procedure. So what they're wanting you to do is pre-oxygenate, set your equipment up, BDM the patient with their airway issues or whatever, and then this thing about first pass intubation is a tracheal tube, which is a magnetic skill. We'll kind of go over and show you kind of what it is, but we'll talk about that. All right. So breathing is controlled by area and what? Lungs, brainstem, spinal cord, diaphragm. So, on to the medulla. Brainstem. All right. So, that's the top volume by observing the chest rise. Chest rise. All right, so we've already talked about this. Otherwise, healthy individual primary stimulus is increased level of oxygen, increased level of carbon dioxide. Carbon dioxide, what oxygen. Signs of inadequate breathing is a pretty good question. Except big warm skin, dry skin, shallow chest rise, natural air critical rate of 16. So pay attention. This is a good question. So turn the patient to the side. Puncture indicated. Semi-conscious patient with a gag, yeah, you could use it for that. But if they fell 20 feet and landed on their head, yeah, they have head trauma or whatever, so you wouldn't use it. If you have a humidifier, we're trying to use a humidifier. But what it's doing is it's drying out the mucus of the nose. Good question. People assist to breathe, but not breathing time. Good question here. You should squeeze the bag. Do it. Hold it 1 second. So again, that's the eye ratio I mentioned. So this is a good question. Sometimes you'll see this. So gastric distension occurs when there's too much air in the stomach. So again, if you get too much in, then it's actually going to come back out. So you've got to kind of keep this in mind. All right, so that ends respiratory. So if you'll give me just a second, I'm going to bring up the pharmacology and we will do it very quickly. All right, pharmacology is a big deal. Very, very, very big deal. So, and there are some medications according to the Georgia Scope of Practice that you can administer. You can administer Narcan, you can administer EpiPen, and again, we'll do labs with these. You can also nebulizer, albuterol nebulizer. You can actually get metered dose inhalers you can use. So there's actually several things that you. So anyway, self-administered medicines is something that the patient takes, you know, a metered dose inhaler or pills. Peer administered either is you're either giving it or you're to yourself or you're giving it to a partner. So this assisted administered medication to a patient is like you've had an example of someone having chest pain and you help them with a nitroglycerin. So many different names of all the different medicines, whatever, and they all have different kind of effects or whatever, actions, indications, or whatever. We'll talk a little bit about these. So a lot of complications, side effects, or whatever. So there, as it says here, there's a very important intervention, and we'll kind of talk a little bit about these. So pharmacology is the science. So it's either used to prevent disease or relieve pain or treat a disease, as it says here. So the pharmacodynamics is where it is the process or how it actually works in the body. All right, this is important. An agonist causes stimulation of the receptors. So a good example would be a metered dose inhaler of albuterol. So whenever they take a puff of it or whatever, it goes to the alveoli and opens them up. So an antagonist, the very best example of this is someone who's taken an overdose of heroin and you give them Narcan up through the nose. So anyway, the action is the effect of the medicine, and you know, it's in it. Hopefully, it will work. So, it is as far as pharmacokinetics. I know this talks about actions of the body, you know, on the medicine or whatever. So hopefully, in the emergency setting, you want a very quick onset of action. Now, there are some medicines that don't last very long, you know. But there's others that hang around for hours or whatever, you know, and maybe 2 hours before they peak or whatever. So we're going to talk about the routes of administration, you know. Now, anyone who's in shock, if they've lost a lot of blood or been involved in trauma or whatever, you pretty much don't want to give them any medication or whatever, because if the metabolism is not good, the medication is not going to act normally or work normally. So contraindications would be someone who's allergic to something. You know, so if they're allergic, obviously allergic to a medicine or whatever, you would never want to give it to them. Adverse effects is any kind of unintended effect. And in fact, I'll use albuterol again. It opens up the lungs, but sometimes it makes them have tachycardia. So their heart rate increases. Now, it doesn't cause them to have tachycardia more than maybe 10 minutes or so. I mean, the heart rate will kind of come back down, but that's kind of an unintended effect. Or an untoward effect is just some sort of unexpected, and you don't see this very much, but it's just some sort of unexpected something going on with the patient. All right, generic name is very simple, and this is what you see most of the medicines in is ibuprofen or whatever. The trade name would be Motrin. All right, then as you see the trade name being Tylenol, the generic name for Tylenol is acetaminophen. So you see acetaminophen most of the time. It's more expensive to buy the trade names than it is the generic names. So you'll hear over-the-counter medicines, and the amount of over-the-counter medicines bought in the United States every year is in the billions of dollars. Of course, all of you know about the recreational drugs or whatever. Weed is a big issue. They talk about it, but they're actually finding some medical uses for weed now. So it'll be kind of interesting to see how it works out. Herbal remedies, all kind of weird type things, but the problem with the herbal stuff is they typically, if you're already taking some medicine or whatever, it enhances the effect of the medicine that you're taking. A lot of people take a lot of vitamins or whatever, and then there are all sorts of alternative type stuff, So this is important. You'll see this on the test. Enteral, it enters the body through the digestive system. And what I mean by that is you take it as a pill or liquid that you drink. Parenteral is you either give it through IV or maybe inhalation to a degree, or stick them with a needle and give them a shot. So it goes into the body in another way. All right, so other common things, you can give rectal Valium for children who have seizures. They do see that. But then, again, most of the medicine is not with us, but most of the medicine across the United States is given by mouth. Intravenous is into the vein, and you have to be an EMT in order to start an IV. Intraosseous is in the bone, and that can be painful, and we'll kind of talk a little bit about this. Subcutaneous is like a TB skin test, or they give just a small amount under the skin, and then intramuscular is deep into the muscle. So any of you that have an EpiPen or familiar with an EpiPen, when you give an injection of it, it actually goes into the muscle, and we'll kind of go over that. Inhalation, again, is in the lungs. Sublingual is a nitroglycerin or some of the other medicines, a few of the others under the tongue. Transdermal is something that's absorbed through the skin, and that takes a while for it to be absorbed through the skin. And then intranasal is a mucosal atomizer device or a metered dose inhaler. We'll kind of talk a little bit about those. So here, this is a good table of the route. So this is in your book, and sublingual is pretty rapid. Rectal is rapid. Mouth is slow. IV is almost immediate. IO is almost immediate. IO is almost as fast as IV. Inhalation is rapid. Intranasal. IM is moderate. So then the rest of it is very slow. So the reason subcutaneous is slow is there's not enough. It's just under the skin, so it takes a little while for it to be absorbed. So the medicine that you're using usually dictates, or the form of it dictates the route. So we'll kind of talk a little bit about that. We'll kind of give you some examples. So anyway, the manufacturer takes care of the route and the timing, for you. That's all figured out. So anyway, there are gelatin shells filled with powdered or liquid medicine or whatever. We'll kind of, you won't see those very much unless it's something for that you're giving for a patient who's a diabetic whose blood sugar is low. So a solution is a liquid measure, and it doesn't separate. So it's given by IV, IM, or sub-Q. And then as it says here, suspension is you have to shake it up before you actually let it take it. A good example of that is Pepto-Bismol. That's a good example of a suspension. So all of you probably have seen a meter dose inhaler, and these are droplets. And so what you're doing, the biggest issue that you see with those is it says here, you look at the same amount each time. People don't use these things correctly. So what you want to do is when they're using it, they have to be breathing inward. So you want to shake it up, put it in their mouth, and then you mash it and let them take a deep breath. That way it actually makes it to the target tissue for long. But it's trying to bronchodilate the lungs. Right, there's also kind of lotions and creams and stuff like that. So a good example is calamine. That was for they use calamine for any kind of irritation of the skin. Or protozoans, anti-inflammatory, which I already know that is for antibacterial. So transdermal is the skin. You'll probably see that. So here's semi-liquid or capsules. Here's the oral glucose. We'll talk a little bit about oral glucose in just a minute. You have to be careful with oral glucose. That patient has to be with it. Can't have anyone who's got a decreased level of consciousness come pour the oral glucose in the mouth and they get choked. So, and you don't think about oxygen being medication, but it is, and it's again one of the gases. So it's usually oxygen is one of the first ones mentioned. Right, this is important. Not patient, not med, not dose, right loop. Right, I've already mentioned peer-assisted, patient-assisted. This is all dependent on state protocols or whatever your medical. So baby aspirin is important. Use these for people who are having heart attacks. You can give them 4 of them, and they work very well. They have clotting, have break up the clot is what they do in the coronary artery. Now, the biggest issues of baby aspirin, whatever, is if they're allergic to it. There's going to be people who are allergic to aspirin, so you kind of have to keep that in mind. Oral glucose, treating hypoglycemia, again, they can't be unconscious. They have to be kind of with it. They have to be able to swallow. So aspirin, if they have any kind of, again, if they're allergic to it, bleeding disorders, asthma is not that much of an issue. We'll talk more about that later. You can't give aspirin to children because it causes a condition called Reye's syndrome. Of this swelling of the brain. Sublingual, under the tongue, it's a very quick absorption of whatever, works very, very well. Usually, I know this talks about, you got to pay attention to the airway. Just don't use a lot if you're putting, most of the time, anything you put under the tongue is small. The sublingual spray, nitro, is very expensive. You just squirt it in, it doesn't go in the tongue, it goes in the mouth. But the little pill bottle actually goes under the tongue. Now, this talks about nitroglycerin, for cardiac patient, increases blood flow, whatever. It relaxes the veins, but also relaxes the arteries too. But it actually dilates and relaxes everything. So, with nitroglycerin, you have to make sure they have a good blood pressure. Because it actually will lower the blood pressure. If you have a male who's taking any kind of erectile dysfunction type medication or whatever, Vitra, Cialis, Viagra, any of those, they can't, you can't give them nitroglycerin, or it has to be over 2 days before you can give it. The medicine has to be done. The other part of it, nitro will cause, under the tongue, it causes them to burn a little bit, and then they'll also develop a headache. But stay away from you'll see this on the test too, any kind of erectile dysfunction medicines, don't give them nitro. It literally will kill them. What it does, it vasodilates them out to the point where it'll bottom their blood pressure out to the point where you can't give them IV fluid, or you can't give them any other, very difficult to treat. So you literally can kill them. So once you open the pill bottle up, storage is very important. Once air gets to it, it's only good for 6 months. So the biggest issue that you see with it is people will say they've taken a nitro and didn't do anything for them. So you can ask them if it gave them a headache or it burned under the tongue. If they said no, then the nitro they've had too long. So again, once it's been opened about 6 months, it's so again, wait 5 minutes before giving it up. another. Make sure you check the vital signs or whatever. Now, this thing about wearing gloves, so reason you anything you touch or whatever, so you have to kind of be careful. Right, intramuscular medications or whatever, you've got to have good stable blood flow to the muscles or whatever, and it is very quick. Anyway, it can be painful because you're looking at, and what I'm talking about is an EpiPen. So if you're using pretty good size needle. A lot of people don't like it, but if you're using it for an allergic reaction, it can be life-saving. So a little bit of pain from a needle is not a big deal. So if they're having an allergic reaction, the only thing that will stop it in its tracks is epinephrine. A lot of people will say, well, you can take Benadryl or whatever. Benadryl will not stop an allergic reaction. Okay. So the only thing that will stop it in its tracks is epinephrine. So here's actually what it does: increases the heart rate. It'll make them have a little bit of tachycardia, constricts blood vessels. If they've got a real high blood pressure or whatever, you don't want to give it. If they're cold, wheezing, any of that, you don't want to give it. All right, naloxone, Narcan for an opiate overdose, fentanyl, heroin, any of this stuff. It can cause withdrawal symptoms or whatever, but if you've got someone who's not breathing or they're about to die or whatever, naloxone can be life-saving. So here they're actually squirting it in the nose, and it works very, very well. All right, so oxygen, we've already talked about inhalation. So here's your nebulizer. This is actually a nebulizer, and it's actually you put the medicine in the little cup there, and it's very fast absorption, easy route, portable or whatever, and it's actually attached to oxygen, so you're actually giving them oxygen, or it's oxygen that's actually pushing the medicine. So it works very well, and it actually, this works better than a metered dose inhaler, and the patients it typically will benefit from it very quickly. This has a spacer device. And they use this with children, especially because with children, it's kind of hard to get them to take a deep breath or whatever. So you let them hold it, and you squirt it inside of this spacer, and you let them breathe, and they keep breathing it until they get the medicine. So it works very well with a child. So now, I know it talks about small volume nebulizers. These are easier than the MDI. It takes a little longer, but it requires a little machine with an external air that actually pushes it. So it works very, very well. Right. So you want to make sure that you've got a set of vital signs, whatever you've done a good assessment, whatever, So be careful about medication errors or whatever. You want to make sure that that you're using calls, whatever, following your medical controls. So this is the last part of it. Pharmacology. So which one is false? So let's talk about it. Like, anything that's over the counter doesn't require physician prescription. We talked a little bit about this, so good question. So IV intravenous is always the quickest one. Metered dose inhaler delivers the same dose of medicine every time, exactly the way it's supposed to be. All right, look at her blood pressure. She's got low pressure, and you're going to give her nitroglycerin. So it shouldn't be given to anyone with a blood pressure less than 100. So kind of keep that in mind. You won't see this used very much, but active charcoal is activated charcoal is an absorbent. So you won't see it used very much. See the effect it's expected to have on the patient's body. So again, you got to have someone who's with it in order to give them oral glucose, because it goes in their mouth, and you actually, if they're kind of out of it, you actually can choke them with it. So kind of be careful. All right, good question. Constriction. So bronchodilation and vasoconstrictions for sure. All right, good question. All right, so absorption. So this pretty much ends 11 and 12. So anyway, good luck studying. Please study.